do cardio, do fitness, go to group, and get my life back on track.
Yeah.
Right? Without going towards substances that are only going to derail your life.
Welcome to the Sober Spill podcast. I'm your host, Isabel. On this podcast, we have real conversations with people in recovery, their families, and organizations that pertain to this field. Today, I'm here with the host of the clinical side of our podcast, Jana Wu.
Thank you, Isabel. My guests will discuss best clinical practices, new emerging trends in substance use and mental health disorders, and how we can best take care of ourselves and our loved ones in recovery.
See you every Thursday.
And come spill with us soon. Good morning.
Good morning.
Hello. Today on Sober Spill, we are very excited to have Dr. Ashwinii Hari-Kurapati, our Assistant Medical Director of Outpatient Withdrawal Management. Welcome back to Sober Spill.
Thank you so much for having me. I'm very excited to be here.
Well, I'm really excited to speak with you because I just want to start with what is outpatient withdrawal management? I think that a lot of clinicians don't really understand what it actually is. So if we can just start there.
Yeah, so outpatient withdrawal management is a program we have here at Mountainside where we reach out to the community and we try to help different people, men, women, with any kind of substance use disorders that they may be having. Now, what we try to do is meet that, individual where they're at. So we have people from all walks of life who say, you know what, my use isn't so bad that I necessarily need an inpatient detox or I need to go to a rehab. But I find that, I'm using substance, X, and it's becoming more frequent and I need a little bit of help getting off of this. So what we do is we meet that person where they're at, which is we set up assessments. We have a medical practitioner. It's either a doctor or a nurse practitioner, see what they need and get the medications to help them with their withdrawal so they can withdraw safely at home. Now, there's a couple of different ways we do this. Sometimes if it's somebody who has a family member who's very supportive and they're able to work with us, then we have that family member help us by reporting back to us, being a secondary person there, being a support person, that kind of situation. If it's somebody alone, for example, I had a wonderful older woman, I think she was around 72, and she wanted to detox at home, and we had the ability to send a sober companion. So that sober companion was wonderful. She stayed with my patient the whole week while I safely detoxed her. And, got my patient anything she needed, even went to the pharmacy and picked up medications for my patient, was able to observe her and really be like a support person there for her so she could detox safely at home.
What exactly, though, let's start with, I guess, what substances can be detoxed at home versus needing a medical detox where you absolutely need to leave your home? How do you determine the difference?
Okay, so a great question. So you tell me the substance, I'll tell you our plan.
Oh, that's a good one. Let's start.
Okay, for example, alcohol and benzodiazepines, like for example, Xanax, Ativan, these are medications that are usually prescribed by a physician for, let's say, things like anxiety, but sometimes it can become addictive. Or sometimes people can get, things like Xanax off the streets. They call them Xanax bars. I've heard that term used. So these are very, very dangerous substances because they're very, very strong depressants. So when you have substances really push your physical functions down, your heart rate, they're sedating, they're very strong, like benzodiazepines or alcohol, the withdrawal is excitation. So the withdrawal is high heart rate, tremors, shakes, possible seizures. So most of the time when these substances have somebody that's really using them severely, it's recommended that they come in for an inpatient detox, right? But other substances, for example, cannabis, for example, THC gummies, for example, I had a patient safely detox from ketamine. It really depends on that person's use and where they're at today. So that is kind of but you give us the patient or the difficulty or the situation that they're in, and we'll formulate a plan.
It's so interesting. I wanna stay with it. There are so many questions I have right now, but I want to stay with one. Let's start with ketamine. It's a really interesting substance. We know it's had a big emergence. It was the way I think of it is like a veterinarian drug. It was very big in the 90s club scene. And now we know over the past few years, a lot of people are using it for treatment-resistant depression and many virtual prescribers. So I'm curious, like, what have you seen in the shift in ketamine use?
So here's the thing that is, I think, very difficult in medicine, which is that certain substances do have, one or two positive effects. Okay, for example, cannabis does help with glaucoma treatment, right? Certain types of glaucoma. It also is very good as an appetite stimulant. If I have a patient who, let's say, had metastatic cancer and breast cancer, okay, ravaged her body, she lost 50 pounds, now she's going home on hospice, that is somebody who could benefit because they're going to enjoy that last 3 months, with their family, and they would benefit from a little bit of medical cannabis. But where these substances get us is where we kind of ignore the chemical nature of the actual substances and release it to the public, and people get very addicted. Now, ketamine is a dissociative anesthetic.
A dissociative anesthetic. Okay,
yes.
What does that mean?
So this is like the type of anesthetic where, where you hear people say, oh, I went in for surgery and I dreamt that I was floating up and I was watching the surgery happen and I was flying above the sky. Like, this causes very powerful, kind of almost, it can be like almost hallucinations during the use. We actually don't use it a lot in the ORs, in the operating rooms, et cetera, anymore. I know that there are, clinics out there and, settings where they say, oh, we can administer this to you safely. But I just recently had a patient who came into Mountainside, wonderful, amazing mom, and she had gotten hooked on it, and her description was that she got it from an online company that was sending it to her. And she came in, her withdrawal wasn't severe, it causes more like, irritation. It can cause a little anxiety. She wasn't, taking tons of it, etc. So her withdrawal was mild. We were able to help her through that. And then she tried to cancel the subscription, telling the online company, I don't want this anymore. They sent her THC gummies. So then I said to her, how do you feel about that? And she goes, what are they doing? Trying to get me hooked on something else? No, I called them. I wrote an angry email. I canceled my subscription. I blocked the email. I threw the THC gummies. I said, okay. So this is happening where we are having commercialization of products that are still very dangerous. These chemicals, the nature of the chemicals do not change. Now, once in a while, you may have a clinical benefit here or there. But I always tell my patients, give me the scenario. Right? Give me the scenario. Give me the situation. If you are seeing a practitioner, it has not become a dependent issue. You are using cannabis for glaucoma, right? Like a very specific type of glaucoma that requires it. You are not overusing it. You are not, dependent on it. You are still a very functional person, and you are checking in with that licensed practitioner. I would say, okay, that's most likely a safer situation. But what we have now is a flood of products everywhere. Kratom at gas stations. I mean, when I was growing up, we had, Moms Against Drunk Driving. And it was a big thing, a nationwide movement where some incredible mothers got together and really changed legislation around being inebriated and getting on the road because it was killing people. It was killing children. Now, we had kratom being sold at gas stations. This is a powerful opioid and sedative. Why you would be selling it to young people who are then getting behind the wheel, it boggles my mind that we have to go back and do this. And thank God, Connecticut outlawed it. And it's now illegal in Connecticut. So
and I think too, when we look at like if it does have health benefits or people using it for harm reduction or pain management, we shouldn't likely be buying our medications at a gas station and then, like you said, getting behind the wheel.
Correct.
Especially, it's so interesting because nicotine was behind the counter, but kratom's like was previously and is still in New York State, like at eye level as you're checking out in many places. I mean, and this is all shifting as we're putting out this podcast. Yes. But I think it is really interesting coming back to like ketamine and ketamine subscription. So when do you see people get hooked on ketamine versus using it medicinally? What would that be? Because I know there are providers that are prescribing it when people are struggling with alcohol use, with disorder.
Right. So this is something that I've seen a little bit in addiction medicine where I've seen, and maybe I'm biased because, I'm a Mountainside provider, but our treatment really focuses on the individual, the whole individual, having them, really appreciating the insight they have into their own condition, into their own use, helping them live their best life by, pushing sobriety more than anything else. 100% sobriety, best life for you, and that's kind of our approach. Now, sometimes what happens is, and I've seen this a lot, where a person will get off of one harmful substance and they'll move on to a secondary substance and then a tertiary substance. And the actual chemical dependence continues. It just
the
shifts.
substance changes.
Exactly. So we avoid that here. And I'm very proud to say I'm part of a team that really, we push the sober life. We push sober living,
Well, I think it's more like trying to get to the root cause.
Exactly.
Like trying to get to the root cause instead of bandaging it with something else to avoid the root cause.
Exactly. And we have these incredible therapists and we have a whole mental health team. And a lot of times we uncover that, let's say a person, is using something, but then they're telling us, I feel anxious. I feel anxious on a daily basis and I'm using this, and I see that a lot where patients self-medicate with substances that they have access to. Anxiety is, very common in our country right now. We had COVID. We had so many upheavals, I will say. In general, people are finding it, very difficult to just lead a normal, happy life, right? Everyone pursues happiness. It's elusive and at the same time simple. And so people will try to say, and I always tell them the three most common depressants that I find my patients reaching towards are alcohol, cannabis, and benzodiazepines. And alcohol and cannabis are now everywhere.
Yeah.
So many patients with anxiety will reach for what's there. So if you reach for alcohol, it will, make you a little anxious in those few hours, but you're going to develop a dependency and the anxiety, once the alcohol leaves your body, is higher than ever before, right? So it doesn't actually fix, or address, I would say, a normal human emotion that we all go through, that in some people, let's say, is more severe and really needs a little bit of clinical treatment, whether it's therapy, whether it's cardio exercise every day, and figuring out, okay, you know what, I actually have a little bit of depression and I can take, medicine that will help with depression, anxiety, do cardio, do fitness, go to group, and get my life back on track.
Yeah.
Right? Without going towards substances that are only going to derail your life. Right?
Yeah. So let's go back to, I know with the outpatient withdrawal management, we have many people that feel like they cannot, for so many reasons. Like I've heard every reason I can think of, which are all valid. I can't leave, even though alcohol use disorder is a disability that a lot of people feel and is federally protected, people feel like if I seek treatment, there will be repercussions. We have many parents that feel like I am the primary parent for my kids. I cannot go to a medical detox. So those are the reasons I mostly hear. But I'm curious, how do you determine, and you said pick the substance, so let's look for alcohol. How would you know if someone was appropriate to do an outpatient withdrawal management versus needing a medical detox?
Okay, yeah, so great questionnaire. We've had, working moms, very busy parents reach out to our OWM. What we first do is a full assessment, figure out how much they're drinking, if they've ever had any concerning withdrawal symptoms before, like seizures, etc. If the drinking is mild, and sometimes, we have patients reach out to us who are already sober for a week or two.
Yeah.
And they just need help staying sober.
Maintaining.
And that is an ideal patient for OWM.
Okay.
Because, their acute withdrawal, which is the withdrawal a person goes through when they, let's say, stop drinking Monday, right? Tuesday, Wednesday, Thursday, Friday, Saturday are going to be tough days, right? Because that's when you're going to have the tremors, the nausea, the vomiting, the headaches. And when it's very severe, you'll have something called, seizures, right? But what we do is we will follow that patient, and we'll see, is this a person who's going to severely withdraw? If they are, let's bring them in and do a safe medical detox here
So
in our
during
rehab.
the assessment, you would see, like,
Right.
this is just not safe.
Right. If it's a person who's already been sober for 10 days, they don't, and we do a SIWA, which is it's a assessment of like how their withdrawal is. And if their SIWA scores are very low, then we know that, you know what, they're pretty safe at home, but they need like a little bit of help with sobriety. And that's something that OWM can really help with. We can also, involve their loved ones if they want that. If they don't want that, we can, offer them therapists, groups, AA meeting. Plus, we have, other programs at Mountainside that, they might eventually also, find some benefits from. And OWM itself will get them a one-on-one with a practitioner. Okay, let's talk about what's going on. Like, what is it that's bothering you? Sometimes people have, like, let's say depression. And when you drink alcohol, which, like I said, is a depressant, your depression worsens that much more, right? Then you just become non-functional at times. And I always tell my patients who have depression, wait like a month, like at least 6 weeks sober, and then let's assess your depression. Because when you're on a depressant every day that's constantly weighing you down, your brain, etc., it takes a little bit of time to see what's your organic depression. And now some patients say, you know what? I've been sober 2 months. I feel a lot better. And I say, okay, let's go from here, And some patients say, I feel better like physically, but I still feel this, they have symptoms of depression, in which case our mental health team will say, okay, let's check your antidepressant, see what dose you're on, etc. So it's really about meeting that person and tailoring that fit so that we meet them where they're at, we meet them in their homes, we're able to get them off of their substance safely, we're able to offer them continuity so that they stay sober, right? Because a lot of times we have our patients say, I was sober a month and then, I relapsed. And I always tell them, be kind to yourself. 1 month is incredible. Let's go from here now.
But how is it different then? So I look at, like outpatient. So someone's doing IOP 3-4 times a week. They're meeting with their individual therapist. They're meeting with the psych provider. How is outpatient withdrawal management different from that?
So the main difference is you get a one-on-one with a practitioner, a medical practitioner, whether it's a doctor or NP, who will prescribe medications to help you with any withdrawal symptoms. So you will also get a medication to help you with mental craving. Right? So let's say it's a busy mom and she tells us, I'm good. I've been now good for 2 weeks, but I feel like I want to drink again. Right? So we get her on a one-on-one session and see what medications we can help give her during this time to keep her sober. Right? These are medications that are, followed by a clinician. She gets a one-on-one meeting every day. She gets blood work.
Okay,
she
so
can
there's blood work, there's one-on-one meetings
one-on-one
with
meetings,
a therapist,
and then
the medical provider.
One-on-one counseling, group counseling, access to AA. Hey, there's an AA group just like, 2 blocks from where you live. Did you know that?
Yeah.
Let's get you in touch with them. In addition to that, we saw that you had been on Zoloft, and this happens with busy moms. The prescriptions lapse, right? And they say, and you had really, demonstrated a lot of signs of depression and anxiety. How about we restart Zoloft during this time to help you, manage your sobriety and manage your feelings.
So it sounds like almost a more curated, like medical experience, because again, with the IOP, you do have access to a psych provider, but it sounds like with outpatient withdrawal management, there's more, do you have a cadence that you're meeting the clients? How often are you meeting the clients?
So for example, that lovely older patient that I had, I saw her every day for, I want to say 9 days total.
And your training is
I am an internal medicine physician.
So she was seeing an internal MD every day.
Yep.
For how long do you meet?
For 9 days. She was well past the withdrawal. She didn't have any more tremors or anything like that. But she had a lovely sober companion from our company that was with her during that whole time. And we were able to, get her sober safely, make sure she was good at home, make sure she was eating and drinking, any observation that the sober companion had, she would also tell me like, oh, she might be a little more tired this morning. She didn't sleep too great last night. Right. And the sober companion also went to the pharmacy and got her the medications that I was using to safely detox her at home and also dispense the medications. So she was taking it appropriately. So yeah, that was one of our patients that I saw every day until I knew that, okay, now she's
Past
good.
the
She's
withdrawal
9
symptoms.
days. She's had me.
Mhm.
She's good. She can now continue with, mental health counseling.
See, I think a lot of people don't even know that's available to them, that they could have access to see a trained medical provider daily if needed
Yep.
to really check in on, the medications, but also like the whole picture of what's actually happening at home and all the symptomology. Can we slow it down too and just go back to, we talked about, seizures. And I know, I had worked at Mountainside and at the VA, and I would work with very healthy veterans, like super physically fit guys. And they'd be like, I am not going to have a seizure. I have withdrawn so many times by myself at home. And I say, well, everyone has their first.
Exactly.
And that it's not about how physically fit you are, but it's actually your brain chemistry. But can you break down what's really happening when someone
Sure.
has a seizure related to withdrawal?
Yes. So basically, when somebody imbibes alcohol, right? I'm just going to use alcohol as an example because it's very common. So again, it's a depressant, right? So let's say this is me. This is Ashwinii at baseline. Okay. This is kind of where I am mentally and physically. Now, if I drink alcohol every day, I am pushing this down because it's a central nervous system depressant. Okay, so I am pushing down my heart rate. I'm making myself sedated. I'm making my brain slow down. I'm doing everything. It's like a big weight. Now, all of a sudden, I stop the alcohol. The weight's gone. Your body is now going to be in withdrawal, and it's going to take time to reset to its baseline. That time it takes to reset and realize that I am here and not here, right? This is the withdrawal. This is the withdrawal that everybody goes through. And that hyperactivity is the high heart rate, the shakes, the tremors. That's your nervous system all of a sudden not having a weight on itself. But it's got to calm down and reattain its baseline. And that's kind of how I describe seizures. So the most severe neurological consequence of your body trying to reset itself to baseline is a seizure.
Okay.
Because it's so hyperactivated now without the alcohol in it that you seize. And a seizure is a bunch of neurons in your brain firing irregularly. Now, most of our neurons fire very regularly, but when that firing is irregular and uncontrolled, that's when it becomes dangerous.
Okay.
So these kinds of patients that are, and I know exactly who you're talking about because I had a wonderful time during my residency treating veterans at the Northport VA. So I'm well aware of this population, wonderful people, incredible soldiers, incredible stories. And so let's say that I have a vet who is 58 years old, and he drinks every day. And he tells me, Doc, I hit it hard, 2 bottles of vodka every single day, right? And this has been going on for, since his wife passed, unfortunately, which is 3 years ago, right? This is somebody we need to have in a medical setting, right? Because the first day that they're off of alcohol, it's not necessarily that they'll have a seizure immediately.
Yeah.
It's the second or third or night or in the shower, right? So this is the reason why we have these patients in a safe setting like a rehab. We monitor their heart rates. We monitor their CWAs. When it gets too high, we send them even to the hospital. I would say somebody that drinks that severely, we may even send them into a medical detox in the hospital because I've been in that setting as well where I've intubated patients and they've gone to the ICU, right? So that's why we want to be very careful with our assessments, and we tell our patients, please be very honest with us, and this is for your best, health and your best interest. And like I said, many of our patients are off of alcohol, let's say 4 days, 5 days. Their CWAs are very low. They have very minimal tremor, a tiny bit of nausea, which we can also treat. And we have no problem sending medications to the pharmacy, making sure that they get the medication safely, and then following them every day until we know that they're in a good spot.
Hi, everyone. Pat McCarthy here. For veterans and military families facing addiction or mental health concerns, Mountainside is here. We accept Humana, TRICARE, and are a proud member of the VA CCN, ensuring accessible, high-quality care. Our specialized programs and staff from military experience understand your journey, providing the targeted support for healing and recovery. If you or a loved one needs help, please call 860-824-1397.
That's fantastic. I appreciate you going through it. And I just appreciate when I say that's fantastic, I just meant I think it's important for people to know that if you are maintaining some like nascent early sobriety, it still could be a time to maybe get some support around the outpatient
Exactly.
withdrawal management.
Exactly.
And I appreciate that breakdown was so good, the description of the seizures. What about delirium tremens? What's going on there?
So DTs or delirium tremens is the name that we give to patients who have alcohol withdrawal. It's the shakes, it's the tremors, it's the nausea, it's the vomiting, it's headache, and severe DTs are hallucinations and seizures, which I explained that's the most severe neurological consequence. And the way we monitor them is CEWA and vitals. And most of the time, our patients who have DTs are in our detox here. And we monitor them very carefully and we make sure their CEWA goes the right way. So sometimes your CEWA goes up day one, day two, then it starts to plateau and we're giving you medications to treat you. And then it comes down. And then we know, okay, this person is gone through the 3-day acute withdrawal and is in a much safer spot now, day 3, day 4. The symptoms are really going to be coming down. We can detox them safely. So we have ways of monitoring them. We are constantly in touch. We have providers on site here. We also have medical support, and so sometimes I'll hear from my nurse, doc, this patient's blood pressure is a little bit, high. That's the most common internal medicine complaint that I get. So I look and I say, okay, they're on day 2 of their alcohol withdrawal.
Okay.
So I would expect that. But we have medications to bring those pressures down safely, monitor them. And I know by day 4, day 5, the pressures are going to come down on their own. Right? So these are the ways that we really, really try to keep our patients safe. And we continue that even in OWM. But like I said, not everybody is, for example, drinking every day 2 pints of vodka, right? So we have what we call the highly functional substance users, right? People who don't even realize that they have a problem. And patients always ask me, doc, how do I know that it's a problem?
That's what I was going to ask.
Right?
What would you say to our highly functioning people that are using now? How do they know if they should be assessed for outpatient withdrawal management or for a medical detox?
Yeah, that's a great question because I've had a patient say, look, I'm killing it at work. I'm a devoted husband. I'm a, devoted father.
Yeah.
Like, isn't it okay, doc, if I do a little bit of substance X? And again, I always ask my patients, what do you want from your life? If you want your best mental health and your best physical health, any kind of dependence. Now, remember, the chemical nature of these substances does not change, no matter how they're advertised. Alcohol was a depressant 300 years ago. It's a depressant now. It's been a depressant since it was, first created, right? Caffeine is a stimulant, but it's not such a severe stimulant as other stimulants, right? So I always tell patients the chemical nature of the substance does not change. And how you decide when it's a problem or when it's not a problem is when it's negatively affecting your mental health or your physical health. And sometimes we'll have patients who come in and say, doc, I'm here because I got 3 DUIs. And, when it gets to that level, I would say that that's a huge red flag, right? That's what we call like the red flags, the eye openers, when it's destroying someone's life, right? Now, you and I know that a DUI is horrible, right? It has major legal consequences, major legal ramifications. It's extremely expensive. It often requires like hundreds of hours of community service to avoid jail time, right? It's a huge thing to get a DUI, right? Especially when you're looking at somebody who's functional and who's, who considers themselves like, on top of their game, right? So I always tell my patients, you tell me, right? And they do. They have the insight. They realize it's creating a lot of problems for me, doc. It's creating a lot of problems in my marriage. I'm missing important meetings, which I never, missed. So many of our patients have this golden word that I call insight. They know it's a problem.
Okay.
So I would say functionality is very big when I assess clinically, like, is this person, functional? But again, functionality can be tricky, right?
Yeah.
Because some people are functional until they have a major car accident, right? So I always tell patients, you have the insight. And we're very lucky. We have wonderful patients that are very open and, they tell us like, doc, it's my wife made me come here. And I say, let's talk about it, so I hope that answers the
Yeah,
question.
so I think I like that the insight and the functionality
Yes.
to maybe seek out the assessment.
Yeah.
And then you talked about some of the physical symptomology before too that someone might see, like the shaking, the nausea, the sweats, the elevated blood pressure, like your body
Right.
telling you and showing you,
Right.
sending you strong signals.
Exactly.
What do you think are some of the biggest misconceptions about outpatient withdrawal management that might be out there?
First, I would say that we are a very dedicated organization, all about helping our patients achieve the best version of themselves, both mental health and physical health wise. And we are private. We can work with a person. I understand the stigma that still exists. I wish it didn't. However, speaking, to defend my patients, who I know how hard it was for them to seek out and, and be here with treatment. One of the first things I tell them when I meet them is, it's so great to have you here. Thank you so much for coming in. Because, we really want to meet people where they're at, and we can do things very privately. We can work with you. We can work with your busy life. I, especially as a, busy working mom, I know how hectic life can be. And we have had, we've had incredible stories where we've gotten patients off of very harmful substances. And that's why I do what I do. I like waking up in the morning and actually helping people have a better, mentally healthy and physically healthy life. And so I get them off of the worst substances. And many times, most of my patients are eager to be sober. They just need some help, right? And so that's why I would say seek help. We're professionals.
I think, too, again, we know there are so many barriers that prevent people from seeking treatment and accessing treatment. So the idea that outpatient withdrawal management allows you to continue to live your life, perhaps go to work, get some additional support. Because you mentioned some people have sober companions, but some people utilize their family. And they don't have sober companions, and they have their family there. Are there some people that can do it alone just with their providers and not a sober companion?
So again, it would be a case-by-case basis, right? So like if I have, a 34-year-old, young woman who has family nearby or lives, in the garage apartments, or families there, they're aware of her going through XYZ, and she doesn't actually need a lot of medications. It's more mental health. I would say that that's an okay scenario where we could work, with just her. And let's say that she was having depression, for which she began to drink alcohol, but she didn't have any DT. She didn't have any tremors. She was not, dependent. She just noticed this and reached out. Then that's something that we could safely get her, mental health counseling, get her services, assess her for depression, see what we could do to help her and meet her where she's at, without necessarily sending a sober companion to her garage apartment, right? So because her parents are right there, and the medications we're giving her are not meds that are potentially harmful for her in any way, right? So we just want to make it as safe as possible for our patients. That's our number one, concern.
Well, they're
exactly.
home. Yeah.
Exactly.
Because we know, and we refer often up to our medical detox, but I think this is a way to, I really was hoping with this podcast we could tell staff too, like when we can refer to outpatient withdrawal management. So how would you say for clinicians out there, they know when can they refer to outpatient withdrawal management to be assessed?
Yeah, I would say like if you have a patient who, admits to you, oh, I do a little bit of this or a little bit of that. And, we clinicians, we keep everything very confidential, and Mountainside's the exact same way. We're very private with our patients. We respect, any boundaries that they may have to the best of our abilities. We're very transparent with our clinical plan. We tell them this is who you're going to meet. This is, how they're going to help you. These are the options we have for you. I would tell clinicians anytime you have a patient, when I was, learning internal medicine, they kind of told us that in the 20s, that's where you see the most substance use, right? So be aware of that. Talk to your patients who are, 20, 21 about, always putting their seatbelt on, always driving, sober, because this was the population at that time that was very high risk for substance use. But unfortunately now that's changed. We have people on substances in their 30s, their 40s, their 50s, their 60s, right? So that model no longer applies to me just being focused on my 20-year-old. So I would tell clinicians, anybody that you feel is at, risk a little bit for doing substances. It's getting to be a little bit more, you're seeing them more often for symptoms secondary to the substance, right? Whether it's hangovers, or you're seeing them because cannabis actually causes what's called cyclical vomiting syndrome.
That's getting a lot of news right now. It's becoming more and more common. Which I'm curious what you think of that too.
Yes.
Why is it becoming more common?
Oh,
The
my
cyclical
goodness. Okay,
vomiting
so
session.
before, when people would, smoke a bit of cannabis, the amount actually ingested into the body was not very high. Okay, so it would be in the body, and then because you're inhaling it, it's absorbed through your lungs into the blood. The actual dosage amount is pretty small. Okay, but now we have THC gummies, we have ingestibles,
And just like
we
the-
have a
The
very
vapes and the
high
dabs, like they're
vapes.
so concentrated.
It increases the amount that's actually in the blood. So
Okay.
you are seeing very severe side effects of cannabis that we've never even seen before. Like, for example, when I was training, I never was taught that cannabis causes psychosis, but now we see cannabis-induced psychosis because the amount ingested is so high, and we call that bioavailability. It's in the blood to such a high amount that you're seeing severe symptomatology. I had a few patients with cyclical vomiting syndrome where basically they can't keep anything down. And after 2-3 days, when you are that dehydrated, you have to go into the hospital and get an IV. Now, I had a couple of patients when I was in the hospital a few years ago. Now I am seeing this a lot more, right? Because it's about the amount that you're ingesting. These are
And the
harmful
bioavailability. you're saying-
bioavailability.
Yeah.
So it's no longer that you're just smoking a joint or you have one, right? Or a joint, or you're taking, let's say, 2-3 inhalations, right, a week. You are consuming like amounts of gummies that suddenly make the dosage so much higher and available in your stomach, right? It's like taking oral nicotine. If you take tons of oral nicotine, right, your symptoms are going to be that much more severe with
When you
nicotine
say
withdrawal.
oral, do you mean like Zins and like the type
Gummies,
of pouches or like things like that though? You can
yes.
just, wow. So
Yes.
can you repeat that again? If you
Yes.
that's very, I think a lot of people are seeking nicotine in, I shouldn't say brand names, but different brands that it goes
Yes.
right in their mouth.
Bad.
And, small.
Bad for you.
So why are they bad for you?
Bad for you guys.
Why? Because people really like them because
So,
they don't smell.
I
And you can
know.
bring them everywhere. So why are they bad?
And so the way that, our field kind of has evolved is that the substances are still out there. They are packaged in very beautiful packets that look very harmless, and they are still, remember what I said from the beginning of the podcast. The nature of the chemical has never changed. Not for 300 years, not for 400 years, not as long as we've had this. The marketing is different.
And the potency.
And the potency.
The potency is
right?
definitely.
Now, why would somebody make nicotine gummies or nicotine lozenges or nicotine pouches more potent? Well, because then a person would have withdrawal if they're not using them, and then they would have to go and buy more of them,
And
right?
now we've made it so that there isn't as much social stigma around it because they aren't affecting other people around you. Because I think that was the big push with
Right.
smoking too, is you're not harming your children, not harming
Right.
people around you. But with nicotine that you're ingesting and doesn't smell and that you're not using.
Exactly. But now you're ingesting a much more potent amount of it, a much higher dose, right? So when you stop or you say, that's it, I don't want to do this anymore, you feel a very bad withdrawal. You feel headaches, you feel shivering, you feel like you can't breathe, you get panic attacks. You know, there's all kinds of withdrawal with these substances. And again, because they're much more potent now than they were ever before. And again, the marketing changes. I always tell my patients, I have very good rapport with my patients. Many of them share with me, the stories about their life, and it's wonderful. And that's one of the main reasons I, went into medicine, to help people. And I always tell them, when a doctor tells you, listen, the sober life is a beautiful life, right? This is not something I'm packaging and selling to you to make a profit. This is for your own mental health and physical health. And Mountainside as well, pushes sobriety like anybody, right? But it is not profiting anybody but yourself, right? Anything else that's packaged, I would be aware, right? Because that packaging is meant to get you to become a lifelong client. And that's the only way to say it.
Yeah.
Mountainside, we love it when you're sober. We say bye-bye, right?
Wow.
Or eventually, right?
Yeah, our alumni department.
Right.
But let's go back.
Right.
So what would you say to someone that is using amount of nicotine that they are like concerned about and they would like to cut back? What would you recommend they do?
Reach out to us. Reach
Okay.
out to us. Get an assessment. It's a bunch of questions that you answer, and we figure out what we can do and how we can help you. Most likely, they would be great candidates for OWM.
For nicotine?
Yes. We could do nicotine.
Wow,
We
that
can
is
do
huge.
alcohol. We
Okay.
could do cannabis.
And
we could do ketamine.
kratom,
we
which
could
I
do
really wanted
kratom.
to talk about because we had
Yeah.
mentioned before, kratom was recently scheduled
Yeah.
in Connecticut. So if someone was out there interested, let's say they work full time, they're really busy, they've got kids, they've got a family,
Mhm.
what would a kratom detox look like?
So
And I know it depends. Like, let's say they're using 7-OH. They're using press pills,
Oh.
7-OH, and they feel like they don't have time to go to a medical detox. They need to keep working. What would it look like?
So, I would say, okay, so, we had a patient in OWM who was on kratom, and again, that plan is tailored to that person. Now, what happened is, this patient, he had been on heroin in his 20s, and he got off of it, thank God, but had been sober several years, and then found kratom, and then got hooked on it.
Mhm.
Okay, and he was on it for 7+ years. So for him, we created kind of a pharmacological treatment plan, which was with Suboxone. Now remember, kratom is a partial. It has two properties. It's opioid and it's a sedative,
Mhm.
right? So it has a withdrawal. And so what we did was we had daily meetings with him.
So when you say
I
we,
did,
okay,
yes.
yeah, daily meetings
Daily
with an
meetings
MD.
with him.
Okay.
And we at first he did not want to be on anything.
Yep.
He was just like, I don't want to be on Suboxone. And it's not like we push any specific plan, but we said, or I had said to him, I feel that Suboxone would help you because you had been dealing with this for a couple of decades now, right? Like an opioid use disorder was really prevalent in his history, right? And at first he was like, no. So we had given him medications. We had given him some medications for anxiety. By day 7, he was off of kratom. He was off of kratom for 7 days. So 7th day, he began to have some cravings,
Mhm.
right? So he reached back out, and we said, okay, this is what we had kind of thought might happen.
Mhm.
So how do you feel now about the Suboxone? And he was eager to try it. Okay, because again, these substances are very, very, very harmful. So a lot of times we'll use a pharmacological treatment. Now, does that mean that he's on Suboxone forever? No, of course not. But somebody who had a 20-year plus of opioid use disorder, right? Unfortunately, now this is his case. This isn't everyone.
Yeah.
Will need a little bit of assistance with Suboxone, right? So we did Suboxone. We were able to keep him sober, and he completed the program. He's still, going to counseling. He's sober, to this day. And that was one of our success stories, right? So we tell every patient now, if I had, let's say, a middle-aged woman, okay, so let's take a 35-year-old woman who was just on kratom, occasional use only, but noticed that it was getting more frequent,
Mhm.
and she's only had it in her life for 6 months.
Mhm.
We could do an OWM,
Mhm.
and she may not even need Suboxone,
Mhm.
but I would still give some medications to treat the withdrawal. She would probably have some shakes and tremors. She would probably have anxiety. And this is all very normal
So
when you
like
come
comfort
off of.
meds, like something
Exactly.
So what type of comfort meds might we use?
So it ranges from like, okay, let's say Neurontin. Neurontin is a medication that is used for neuropathic pain, but it's also kind of a sedating medication. It's used for alcohol withdrawal. It helps with things like mental craving. We can use, so this patient, let's say she also had a little component of anxiety. We can use medications that are not addictive, but for anxiety management. We could use also, let's say she might have like an occasional panic issue, right? So we can use propranolol, which is a non-selective beta blocker. It's used for acute stress disorder, or what we call panic attacks, to help her ease through that time period of withdrawal from kratom. What are some other medications? Okay, so sometimes these patients, like I said, busy moms that let things like Zoloft lapse.
Yeah.
So we restart them on antidepressants, low dose, see how it goes. Many times because they're coming off a opioid use with kratom, they'll have a lot of nausea and vomiting. So we can use medications like Zofran, which dissolves under the tongue. It's a sublingual form, so they don't have to swallow it while they're vomiting. They just put it under the tongue and it dissolves. Reglan, these are all antiemetics. This helps with the nausea, vomiting. So these are some of the medications that we use. And again, because that woman, that example that I gave, the 35-year-old woman who's using kratom sporadically, right? Her withdrawal most likely isn't going to be severe. So these medications will get her through the hump, and then our long-term plans for sobriety will keep her sober and away from that.
Yeah.
And that's the ultimate goal.
Being able to get through that discomfort enough to make the behavioral changes or have the clarity of mind to get to make different decisions for yourself. Wow.
Exactly.
It is an amazing opportunity. I think of like the ability to meet with like an MD every day if needed, and then other supports like you mentioned, a nurse and like a therapist, and then be doing the groups. Like that's an incredible opportunity. And it's sort of we're in this world now of a lot of people self-dosing and self-medicating, getting their doses from ChatGPT and ordering, meds on the gray market. And designer benzos have had a huge reemergence now.
Yes.
They've always been big for like the last 10 years, but now we're really seeing a lot of people really taking their healthcare into their own hands. And I love the idea of someone getting the opportunity to really connect with like a physician, to really talk about maybe what they're thinking, and they're posting in the I won't use names, the different threads and the different, places where people can post their symptomology, but to actually get feedback from a living, breathing professional that has studied this for years is incredible.
Yeah, I've been Suboxone certified since 2014.
So over
12 years.
Yeah,
Yep.
over a
I got my
decade.
waiver in New York. And now, because unfortunately, opioid use disorder is so widespread, nobody could have predicted this. But now, because it is so prevalent in New York and Connecticut and, the Northeast, in our country, period, many doctors don't even need to get the waiver anymore. They're able to prescribe the Suboxone as an internist, as a family medicine physician, et cetera. I would say that, anybody struggling, please reach out, please get help. Don't be, worried about stigma. This can all be done privately. And we have excellent resources. Use us as our resource. And even, I think Mountainside is great in the sense that we really help people get what they need. If you can't come to an inpatient or anything, or if you can't come to an IOP, well, hey, we have connections with AA. Let's get you connected, right? We do everything we can for the best for our patients. And that's really why I work here. It's so that we can just do the best we can to help our patients get off of these harmful substances.
Why is it called outpatient withdrawal management and not ambulatory detox anymore? Are they the same thing? And I could probably put this in front.
Yeah, so ambulatory is just a fancy way of saying outpatient.
Okay.
So for example, you'll have ambulatory surgery. It doesn't mean you're getting surgery in the in the house. It means that you're going in for the surgery but going home immediately after, right? So ambulatory detox is pretty much the same thing as outpatient withdrawal management. The only difference I would say is that sometimes, and we have this as well at Mountainside, we have a center where patients will come in and they'll get their, let's say, Suboxone in the morning, have an hour of group. I know we have the center in New York City, which is amazing. I know they do yoga in the center as well. So they get their Suboxone, they get their hour of group therapy, then they do their yoga and they feel good, they go home, right? And that was like an ambulatory detox, right? Now, outpatient withdrawal is saying we can, get you some of those resources as well and meet you at your house if you so need us. And again, not everybody has to do OWM. It really depends on your needs and kind of where you're at. And we're happy to meet you where you're at. And that's, I think, the big resource offer that we can really, get out to our patients. Like, what do you need? Do you need intensive outpatient? Do you want to come to our center, do a little yoga, do a little group and go home? Do you want us to meet you at home with our doctors and get you a very catered, tailored, custom plan to get you to living your best? However we can meet you, we will meet you. You just need to get in touch with us and tell us what you need.
Thank you. Anything else?
That's it.
That's it? Okay.
Thank you. And happy early Mother's Day.
Thank you. Happy early Mother's Day, too. Any questions, Casey? Questions in the corner.
Yes.
So if my partner, loved one is not interested, is there anything that you guys can do to help educate or encourage or?
Yeah, so that's a great question. The question was if somebody's partner or loved one needs help or has a substance use disorder and they're not willing to come in, right? Or they're not willing to give things a chance. I mean, we have a lot of resources at Mountainside. I know we even have like educational pamphlets about some of our programs. And I know that sometimes people prefer informal settings where they just come and meet some of our, professionals, our mental health care team, and, just sit down and even assess if like, hey, is this something right for me? And sometimes I tell, my patients' families as well that, it is difficult. I would say just try to get the information to them. And the more we talk about it, the less of a stigma it is. But substance use right now in our country is so tremendous that, we have addiction medicine as a whole field, apart from internal medicine, not just internists that have treated this, but medical students who actually go into this field to become practitioners only in this field. And that just goes to show you how prevalent this is, right? So we have to just talk about it openly and honestly and try to remove any stigma. And I would say be kind to that individual, your partner or your loved one. Be kind to yourself as well, and get resources to them and see if, there's a lot of positivity in this field too. Like when you see people's lives transformed because they're able to stay sober, they win back their family. We are role models, all of us, for our children, right? So they live their best life. It's very uplifting.
Yeah.
That's why I do what I do. So I would say all of those things, and I would say be kind to them, be kind to yourself.
And if you are by any of our outpatient locations, Ramsey, New Jersey, Huntington, Long Island, Chelsea, Manhattan, 18th and 8th, Wilton, Connecticut, up here, of course, in Canaan, Huntington, Long Island, you can always call and schedule a visit. We do allow family members to come and take tours. Of course, we schedule it when there won't be clients around, but if that is an option to allow people to feel more comfortable, that's also an option.
If you or a loved one is struggling with addiction, Mountainside can help. Call 860-365-6764 to speak with our caring treatment team.